Welcome back to Your Health. I'm Dr. David Morwood. I'm a board-certified plastic surgeon, and my next guest is Dr. Alan Clark. Dr. David Alan Clark, thank you very much for being here. Thanks for coming on the program.
Thank you very much.
Dr. Clark, I read your CV, and it's very impressive. Professor of cardiology at Stanford, and you practice here in Monterey. Thanks very much for being here.
Thank you.
Dr. Clark, I want to talk a little bit about what your average day is like and what your average week is like. What's a cardiologist do?
What's a cardiologist do? Well, we aim considerably higher than the pelvis, which would be different than your other two first guests. Basically, the idea of a cardiologist is to take care of hearts and arteries. And so cardiovascular disease is really the specialty, and it includes a lot of hypertension work. But from the standpoint of what you asked me here today to talk about with stents, interventional cardiology takes up a couple of days a week in a laboratory, usually doing interventional procedures, and the rest of the time taking care of patients with medically treatable conditions and trying to diagnose those conditions with stress tests, echoes, nuclear tests, and so on.
So, Dr. Clark, when we say interventional cardiologist, what do we mean by that phrase?
Okay. When I did my training, invasive cardiology was the term, because at that time we could put something through the skin, which is what invasive is, and get pictures of the arteries that supply the heart, the coronary arteries, and this was called cardiac catheterization or coronary angiography. And when I did my training at Stanford in the late 60s, early 70s, it was actually an elective. It wasn't thought to be that terribly important, but as it turned out, in 1971, the first bypass surgery was done, and then it made sense to be able to look at the arteries and see where blockages were because you could fix them. First angiogram was done in 1958 by Mason Soanes in Cleveland, but for quite a spread of time there, you could take pictures and say, yeah, you got it, but didn't have really anything to do mechanically to fix it anyway. But you could distinguish between chest pain that wasn't heart pain and true heart pain. And then in the late 1970s, 1978, Andreas Grunzig in Switzerland performed the first balloon angioplasty in the heart arteries, which meant putting a balloon in the artery in the heart, expanding it, compressing the blockage material, the plaque. And so cardiologists were then able to fix the arteries as well as diagnose them, and so it went from an invasive term to an interventional term. So interventional really means you're fixing something, I guess, in terms of cardiology, and then stents followed that as a way of making the interventional procedures better.
Okay, so Dr. Clark, let's review for our audience. Now, of course, most people know that it's the job of the heart to pump blood throughout the body and to the lungs to get reoxygenated. But we know that the muscle of the heart itself needs a blood supply. Isn't that true?
Correct.
So how is it that the muscle of the heart itself gets a blood supply?
Well, the heart pumps blood and it goes out through the aortic valve into the aorta, which is the main artery off the heart. The first branches off that aorta circle back around and supply the heart muscle. So God was pretty good in his design of that he gives the first fuel that comes out of it right back to the heart to keep it pumping. Okay. And so when those arteries get blocked and shut off, that's what causes a heart attack, the coronary arteries.
Okay, so the heart itself has special arteries assigned to deliver blood to the heart muscle itself.
Right. The blood that's in the heart being pumped around does not directly nourish the heart muscle from inside the pump, basically.
Okay. So for our audience, again, to review, so problems can occur with those vessels and arteries that are assigned to deliver blood flow to the heart muscle, right?
Right.
And that's coronary artery disease.
Right.
Right? Now, do we still call it, or is it accurate to say hardening of the arteries? Is that what people call coronary artery disease?
Well, that's what it was called in sort of old days, but all arteries get harder as you get older. If you take an artery out of a young person, it's a fairly flexible, easily movable structure. If you take an artery out of maybe you or me, you could probably bang it on the table like a pipe. And so arteries get harder in the lining of the arteries. The arteries are a thick vessel, and they have three layers of lining around them. So those layers can develop calcification over the years, and they can get harder. But what you're looking for is on the inside of the artery, you're looking for a plaque buildup that doesn't allow the blood to flow through the artery.
Okay.
Okay.
Now, Dr. Clark, do those arteries ever spasm? Like we talk about a stressful situation bringing on a heart attack or a myocardial infarction. Now, do those vessels ever get affected by stress and spasm off, or is that just a so-called wives' tale?
No, they do. One of the layers in the artery wall, not the heart wall, the artery wall is a muscular layer. And so having a muscular layer, it can spasm like any muscle can in your calf, or otherwise there are different types of muscles, but they can spasm too. And I'm not sure when it was, but a long, long time ago, a doctor named Prince Metal described this as a cause for both heart attacks and for chest pain. And those arteries can spasm and shut off. It's called Prince Metal angina, after this fellow that first described it. And we have tests that we can do in the angiogram laboratory to provoke spasm in arteries, and then take pictures of them and see if they do spasm, and then usually always relieve them with nitroglycerin intracoronary right into the artery. But then the treatment for that would be some anti-spasm type of drug like the calcium channel blockers, or even if they don't work, long-acting nitroglycerin type drugs. But there is spasm in the arteries that can cause heart attacks, and usually that type of, if you get discomfort from that type of pain will come on sporadically. Not predictably with exertion like heart pain often does. Not always does, but often does.
Okay, so Dr. Clark, let's back up a moment. You mentioned chest pain,
Yep.
of course. Now let's just, for sake of discussion, say a 60-year-old man comes into the emergency room, no personal history of heart disease, and he complains about that substernal or deep chest pressure and pain. He's a little bit short of breath. Now, and the cardiologist is called. Now, how do you assess whether or not his symptoms are due to a problem with the cardiac artery or coronary artery? How do you work that up?
Well, initially in the emergency room, you do an EKG. And if an artery is shut off and there's some heart muscle that's not getting the proper blood supply, then the EKG will change shape in a way that's typical of that happening. It's a pattern recognition sort of thing with the EKG. If the EKG is not changing, then you usually try to relieve the pain with nitroglycerin to see if that goes away. If it does, nitroglycerin can relieve other pains, but it also specifically relieves its coronary artery pain, pain caused by the coronary artery blockage. And then you would look for enzymes in the bloodstream to see if they've been released by the fact that there was no blood supply to the heart muscle. If the heart muscle is deprived of blood supply for about 4 hours, it'll disintegrate, release enzymes that are in each individual, and these are millions of heart muscle cells, and then that'll show up in the bloodstream, so you can tell, yes, this is pain because of a blocked coronary artery, and the blood cells are affected. I mean, the heart muscle cells are affected. And then if that were suspicious enough, or if the initial EKG were abnormal, you'd probably go directly to the heart catheterization laboratory, do an angiogram, try to find the blockage and fix it with angioplasty and stenting, presumably, hopefully,
okay,
before it shuts off and damages the heart muscle.
Got it. So let's talk for a few minutes about the angiogram, the coronary angiogram, and angioplasty, and then placement of a cardiac stent. Okay. Let's talk about those three phrases or three terms.
Sure. An angiogram is a diagnostic test only. It doesn't fix anything. So that's what we started doing in 1958. And you put a catheter into the artery system somewhere. On the West Coast, that was mainly done through the artery in the groin, the femoral artery. On the East Coast, it was done mainly through a cut down on the brachial artery in the arm. It was just who started it where and who trained people to do different things. Now it's pretty much always from the artery in the groin or the leg, although recently some of my colleagues at Stanford have been doing them through the wrist artery, through the radial artery. But somehow you have to get into the artery system. You then introduce a little catheter that will reach from wherever you put it in, presumably the groin, up into the heart area, and position it just at the beginning of these coronary arteries. So it's just above the heart. Remember, and the arteries that supply the heart muscle take off right away. So you position it there at the origin of these arteries and inject dye. And what you're trying to do is fill the artery with dye and see if it's clean. Think of the artery as a water pipe. And if you've got a nice normal artery, you'll see a nice smooth column of dye going through it. If there's a blockage at a particular point, then the dye comes out. It has to narrow down to go through the plaqued area and then open up again. So you can actually see where the blockage is, how much it is by measuring the opening of the artery there and on the normal side, on either side, and tell whether it's important or not.
And you're doing that all remotely, for example, through a small incision in the groin or through the wrist.
Yeah, sure.
You can kind of snake up your little catheter through that artery up to the heart where you need it to be.
through the big aorta. It's let in by a soft wire that has a little J on the end, so you don't hook on any plaques if there's plaques in the aorta.
Okay.
And then it goes around, you position it right at the beginning of the artery. So this is like standing outside of a house and saying, hello, anybody home? You're not really going into the artery, but you're injecting something so you can see what the inside of the house looks like and what the rooms look like.
Okay, so then you're injecting the dye, and then you see the image with x-rays, is that right?
Right. Now it's digital, but it's, X-ray X-ray machines.
Okay, so then go on to discuss angioplasty. Let's say you get a picture or a radiographic image, digital or otherwise, that there is a blockage. What's your first step?
First step is to make sure that it's a blockage that would be appropriate for angioplasty. And more, a lot of them are. There are some areas that are still the purview of the bypass surgeon. But in recent years, people have started to trend to go to triple vessel disease, where there's blockages in all three major arteries. There's usually three, sometimes two, sometimes four, but the major arteries. People thought you'd get a better long-term result with bypass surgery than with angioplasty, or the left main artery, which is important particularly because the left two arteries take off from the aorta usually. The right coronary artery, which supplies the bottom wall of the heart, and the left main artery, which splits into two, one going down the front side of the heart, one going around the back side of the heart. So it's a three-dimensional organ, obviously. If the left main artery is involved and it shuts off, people usually die. They don't survive that because suddenly they've lost 2/3 of their heart muscle. And the 1/3 that's left can't keep functioning. If one of these three main arteries shuts off, they'll often survive that, but be left with a scar. So you look at it to make sure that it's something you should do. And if it's something that you should do, it would be, yes, this person, if we didn't have angioplasty, should go to bypass surgery because it's important to do that. Shouldn't just do angioplasty because there's a blockage there. And is it safe to do? And then if it is, you have a little different catheter. It's a little bit bigger opening in the catheter. But you put another catheter in the same route that you used from the groin or wherever and advance it to the opening of the artery, and then through that catheter you pass a little wire that will go down the artery across the blockage and put it distal or beyond the blockage. And this wire is 14 thousandths of an inch. That's about like your head hair. And you again manipulate that from the leg or the arm or wherever you're doing, and it has a little bend on the end so you can steer it. And then once that's in position, you pass a balloon catheter over it and position the balloon where the blockage is. Now you've got a balloon that's probably just about blocking off the artery. So you rather quickly inflate that balloon with a lot of pressure, compress the material up against the walls of the artery, and then deflate it. And this acts like a kitchen compactor, so that you can take a bunch of garbage that's inside the artery and compact it into a smaller package, and it stays there. And that's where the stents came in. Some of them reoccurred, and you wanted to have something that would keep it there better. So stents originally came from a dentist, by the way, that used to use them to keep teeth in place while he was working on other ones or something. I'm not sure what that history is, but that was the name of it, and the guy's name was Stent, so that's where the word came from.
Well, Dr. Clark, I understand that you actually helped to develop some of the early stents. Isn't that true?
Yeah. Yeah, I was working up at the San Francisco Heart Institute at that time, and we decided because some of these arteries were not staying open that we were fixing with angioplasty. And in the early days, before stents, there was about a 3% emergency surgery rate where they wouldn't stay open, you had to go to surgery. And stents were really invented to kind of prevent that, and it's done that. The emergency surgery rate now is less than 1% with stents. But while I was in San Francisco, there was a particularly wealthy person there who had to have a couple of angioplasties, and he was an engineer, and he got one of my partners up there out to his garage, and they invented this stent, just a little metal curlicue thing that you could put in over after you did the balloon, you'd put this in. And the first ones that we tried from this guy's garage, you had to flush in some hot water, and it was heat expandable. And that was a little bit of an interesting, anxiety-provoking moment when you flushed hot water in the coronary arteries. But later on, Grunzig and some others advanced to use a balloon to open it, which made sense because the balloon will open these stents, and then they'll stay open. They're prefixed to stay open.
Well, Dr. Clark, of course, on everybody's mind, with all these medicines that people take after having a stent placed, everybody wants to know, well, don't they clot off, or don't people make more clots or atherosclerotic plaques? Like, does the stent actually prevent further disease from occurring?
No, not at all. That's where prevention comes in. You've identified this patient now, you've had to put a stent in him, so you know he's at high risk to develop blockages elsewhere in the coronary system because he's already done it once. So that's when now we're trying to get the the LDL or the bad cholesterol down to 70 instead of 130 in patients like that. And we try to get hypertension under control, diabetes under control, all the risk factors under control, stop your smoking, all that sort of stuff. So once you've identified a patient, they become, right at that point, high risk, and you have to really work hard on prevention. The stents themselves stay open. We've had no long-term failures of stents. There were short-term failures because of scar tissue. Whether you did a bypass to an artery or whether you put a stent in an artery, it's a controlled injury in the artery, and it reacts with scar tissue. And so the medicated stents came out about 4 or 5 years ago. And the medication is to just prevent the wall of the artery from forming scar tissue. And it wears off after 3 months, and then you're left with the same stent you had before the medicated stent, but you've gone away from that early recurrence rate, which was always scar tissue.
Okay. Dr. Clark, we've only got about a minute left. Now, I want to make sure that we give out either your website or a phone number, how people can contact you.
Sure. Phone number here in Monterey is 649-9330, and we're on right on El Dorado and Cass.
Okay, so that's David A. Clark, cardiologist right here in Monterey.
Right.
Now, we've got about a minute left. Now, what other kind of issues do you people, does the cardiologist take care of besides placing cardiac stents? I know there's pacemakers, and you handle cardiac arrhythmias, and you help people with their medications, and you mentioned cholesterol, et cetera.
Sure. Mainly, pacemakers and arrhythmias and that sort of thing, I usually give to the purview of a trained electrophysiologist in the heart. They're trained for another couple of years in how to take care of electrical problems with the heart, just as I was trained a couple extra years to do invasive and interventional. And otherwise, it's hypertension control, diagnosis, treatment of the coronary disease.
Well, Dr. Clark, it's great that you come on the program.
Thank you.
You guys do such great work, and I'm amazed just mechanically how you snake up that little catheter up and put in stents and do the angioplasty. It's very impressive.
Thanks.
I still love plastic surgery, but I'm a little envious about what you guys do.
Well, I'm envious of your musical career, too, so that's okay.
And you're a clarinet player. We should
As a matter of fact, I don't want to advertise this, but I'm going to give you this. That's my album that you should see.
Dr. Dave going to the dogs. Now,
Right,
there's great publicity. Dr. David A. Clark, cardiologist here in Monterey.
Okay.
Thanks very much for coming on the program.
Thank you.
I'm Dr. David Morwood. This is Your Health radio and television program. I am a board-certified plastic surgeon. Thanks for joining us. And please come and watch and visit the program again. Thanks for being here. Great of you to come on the program.
Yeah,
Thanks for
thank
being